We're discussing the role of exercise, both physical and mental exercise, on cognitive slowing. There is a variety of levels of motivation by patients. So you will find some that are extremely motivated, and others who need a bit of stimulation by family members and by their physicians. With the doctor's help, with the doctor's kind of strong motivating words, you hope that you have to convince, you have to get buy-in on the part of the patient that whatever they're doing, and this, I believe, we're being increasingly successful, since we as physicians are believers, are starting to believe that the evidence is there. We can transmit that feeling to the patients and to their families. So that creates more of a motivating environment that will allow for them to act upon our recommendation and hopefully slow down cognitive decline. This, of course, within my specialty would be Parkinson's disease, but even would apply to just about the whole area of medicine and geriatrics. The evidence is that, in fact, people overall do better over longer periods of time, and that not only does the physical exercise allow them to perform better and have a better cardiovascular conditioning, which itself will have a good effect on health in general, but it will also improve their cognitive function, meaning they'll be able to mentally be more agile, and that this will have an effect over the long term. It's a matter of both. It's a matter of, actually it's a matter of slowing down the progression. But yes, if you're more fit, then if you suffer a fall, you'll be able to pick yourself up in a better way. So in a simple effect as that. So yes, it would have an effect both in the conditioning of the individual to be able to put up, after all, patients, say with Parkinson, have to fight against the resistance. They have rigidity, have slowness, they have to invest more energy into counteracting that effect. And in the better shape they are, the better off they are. But in addition to that, there is the factor of actually slowing down the progression of the disease. There are two wide areas that are being looked into. One area has to do with investigating in large patient populations the degree to which they lead active mental lives, meaning socially interactive, participating in a lot of social activities, or getting involved in hobbies, or anything that actually is introduces a factor of novelty. In this constant novelty exposure and challenging oneself. And you can study populations over a period of years, and you have to tease out the effect of doing this lifestyle versus many other things, like if they are highly educated or not as highly educated and the like. And still, even once you tease out a number of other possibly confounding factors, you will still identify factors exclusively related to just being cognitively involved. There is a concern about so-called reverse causality, which means that the person who is already, by virtue of perhaps higher education or higher motivation, are already predestined to be the ones who will seek more novelty. But even when they try to tease that out, even then, if somebody's actively trying to be active mentally, that would seem to make a difference. A different area from just plainly the lifestyle people choose is whether, in addition to that, there is a cognitive effect that is a positive, a good cognitive effect by virtue of practicing with certain games. And I don't want to mention trade names, but there's a number of trade names and claims that have been made. And this has been studied, and it seems that you can train yourself for that particular game. And for that game, you may end up being particularly good or showing signs of benefit, but it's not that clear that it transfers to other areas of real life. So that is still in question. We don't think it hurts, but we still need the proof that it helps. The final aspect has to do with physical activity itself. So physical activity, a daily dose of exercise, which we're still trying to find a dose. We don't have a dose for exercise. We think that maybe aerobic activity for 20, 30 minutes a day would be a good start. Aerobic can be as simple as walking and establishing goals that do not have a side effect orthopedically or cardiovascular. So you don't want to create side effects from a treatment that actually is trying to just improve your cognition. So that's another aspect that seems to be very strong for the good effect of physical exercise on cognition. It has become a very big part. It used to be a side conversation. It's now probably among the top 2 or 3 items that you're going to talk to your patients about. So if somebody has early Parkinson's disease, the first item that you'll talk once you have made a diagnosis, you have allowed the patient to ask questions about the diagnosis, you allow them to digest the diagnosis, sometimes more than one meeting for that. But once that Rubicon is crossed, and now we're talking about planning of treatment, first item of business is exercise. Let's just get that out of the way, make sure that the patient understands exercise is the medication of choice. After that, you can start talking about medicines also. We believe that it's becoming increasingly apparent because the amount of evidence and publications that come out can be counted in the high hundreds at least. So it's become increasingly obvious. It's the subject of editorials in mainstream neurology journals. So it's become ready for prime time, and it shows in our literature. My vision of it is that we will be determining closer and closer, in the same spirit of precision medicine, a dose for every patient of exercise. And we would have to be as holistic as possible with regards to not only the patient's age, their cardiovascular status, their orthopedic status, and their neurological status, and converge all three into a dose for any particular patient.